Welcome back to the Deep Dive. Today we're getting into the weeds of a really technical medical procedure, trying to find those little details that make all the difference.
We are. We're looking at short-term nutritional support.
Specifically, the placement of a nasojejunal tube, or NJ tube.
Yep.
And our source material for this comes straight from Dr. G.S. Raju's YouTube channel. It's Lesson 14B, which is super detailed on this exact procedure.
It is. And our mission today is pretty straightforward. We're going to break down the how and, more importantly, the why of placing this tube.
Right.
It's a real study in precision. I mean, success really hinges on having the right gear, a ton of pre-planning, and this surprising focus on, of all things, friction.
Friction, really. Okay, that's interesting. I think what stands out to me right away is just how high the stakes are for something that's, well, it's just a temporary fix. So let's start there. What's the main role of this NJ tube?
It's strictly for short-term feeding.
Short.
We're talking a few days, maybe up to a couple of weeks. It's for patients who can't handle feeding into the stomach, but the clock starts ticking pretty much right away.
And why that hard deadline? Why only a couple of weeks?
Well, you have to remember, it's an invasive route. Keeping a foreign object going through the nose, the throat, the esophagus for a long time, it just dramatically increases the risk of infection, irritation, all sorts of complications.
I see.
So the source is really clear on this. If that patient is going to need feeding for more than 2 weeks, the team has to pivot.
Pivot to what?
To a more permanent solution, like a PEG tube. A percutaneous endoscopic gastrostomy. It's surgically placed, much more stable, and carries a lower risk for long-term use.
Got it. So given that it's so temporary, the preparation has to be, what, flawless?
Absolutely. The setup includes the NJ tube itself, which goes over a guide wire. You also need lubricant, saline, and a really good line of communication with the anesthetist, to keep the patient comfortable.
And patient comfort is where that first big decision comes in, right?
Yeah.
Even before they touch a scope, there's this critical step.
Yes. Applying local anesthetic to the nostril. But even before that,
Right.
the endoscopist has to figure out which of the patient's nostrils is bigger.
That seems like such a small detail.
It's fundamental. So many people have a deviated septum. If you try to force a scope through the smaller side, you're just asking for trouble. It could cause trauma, and you might just fail the procedure right there.
So you have to pick the path of least resistance from the very beginning.
Exactly. The whole procedure's trajectory depends on that one initial check.
Okay, so once that choice is made, we get to the first method, the preferred one. It uses a very specific tool, right?
It does. A slim EGD scope. It's really small, about 4.9 to 5 millimeters in caliber.
It has to be that thin to go through the nose.
Precisely.
Yeah.
And again, where you place it is critical. The endoscopist has to guide that scope along the floor of the nostril.
Floor. Why is that so important?
It's purely to avoid immediate failure. If you aim too high, you're going to get caught in what are called the turbinates, these little bony structures inside the nose.
And the scope just gets stuck.
Instantly. Procedure's over. So you go along the floor, through the pharynx, esophagus, stomach, duodenum, and then you push it deep into the jejunum.
And the source mentions a little trade-off with this slim scope, doesn't it?
It does. Because it's so slim, it can be a bit, well, flimsy is the word they use. You can add a stiffening wire to give it some stability.
But there's a catch.
The catch is you lose your suction capability. So it's another one of those in-the-moment clinical judgments.
Okay, that makes sense. But the part of the prep that really floored me was about the guide wire and the assistant's role. It sounds like success or failure can hinge on this one tiny action.
You're talking about flushing the guide wire.
Yes. The fact that it has to be flushed and moistened while it's still in its casing before it even goes near the patient.
It sounds so minor, doesn't it? But think about the physics involved. This wire is really long. It goes all the way down the GI tract. If it's dry, the friction between that wire and the inside of the scope is huge. And the source explicitly says that if you skip this step, the endoscopist will struggle to pull the wire out later on.
And that struggle could dislodge the tube you just placed?
It could pull the tip right back out of the jejunum or just cause irritation. So it's a simple little step that prevents a massive risk down the line.
It's foresight over struggle.
I like that.
So the wet guide wire goes through the scope into the jejunum.
Yeah.
Then the scope comes out.
Right. And this is where the assistant's job becomes like a tightrope walk.
How so?
As the endoscopist is pulling the scope out, the assistant has to hold on to that wire. They have to keep just the right amount of tension.
Too little and it slips out.
It slips out too much and you could cause an injury. It's a very synchronized, very high-stakes moment.
Which brings us to imaging. I guess this is where you'd want to see what's happening.
For sure. The source notes that a really experienced person might do this blind, just by feel. But for anyone who's a novice or just for extra safety, you use fluoroscopy.
So a real-time X-ray.
Exactly. It's your safety net. You're watching for two main things. First, that the tip of the wire doesn't slip out of the jejunum.
And the second.
And second, that the wire isn't forming a big loop inside the stomach, because if it coils up in there, you'll never get the feeding tube to slide over it.
Okay, so now the wire's in place perfectly. Jejunum to nostril. It's time to slide the actual feeding tube on.
Yeah.
I'm guessing more prep is needed here too.
You guessed it. It's all about minimizing friction again.
Of course.
So you have to flush the tube's internal channels with water or saline just to prime it. Make sure it slides easily over that wire. Then, as it gets near the nose, you lubricate the outside of the tube.
And then comes the final slide.
The moment of truth. The assistant keeps that little bit of tension on the wire, and the endoscopist just slides the NJ tube all the way down until it's in the right spot in the jejunum.
And then the wire comes out.
Wire comes out, tube gets secured to the nose, and that's the ideal scenario.
The ideal scenario.
Yeah.
But Dr. Raj's lesson prepares for reality, which is, what if you don't have that fancy, expensive, slim scope?
Right. What if all you have is the regular, wider EGD scope that has to go through the mouth? Now you're in a whole different ballgame.
Okay, so how does that work? You can't put the tube through the mouth. It has to come out the nose.
This is where it gets really clever. It's a fantastic example of having to improvise. The scope goes in the mouth just like normal. The guide wire is placed in the jejunum, and it's exiting the mouth.
But you need it to exit the nose. How on earth do you get that wire from the mouth to the nose?
You have to do this this kind of rerouting maneuver. You take a second, smaller plastic tube.
A completely different tube.
Completely different. And you pass it from the nose down through the pharynx, and you grab the end and pull it out of the mouth. It's like a temporary tunnel.
Wow. So now you have two things coming out of the patient's mouth, the main guide wire and this new temporary tube.
Exactly. And then you take the tip of the main guide wire, the one in the jejunum, and you thread it into the mouth end of that little plastic tube.
You're kidding.
Nope. You feed it all the way through until the guide wire tip pops out of the patient's nostril.
That is an unbelievable workaround.
It is. And once the guide wire is rerouted, you just slide that temporary plastic tube off and discard it.
And now your wire is correctly positioned coming out of the nose.
Correct. And from there, the steps are the same. Wet the wire, flush and lube the NJ tube, slide it into place and secure it.
That just requires an incredible amount of dexterity and teamwork.
It's procedural mastery, really.
So no matter which method you use, you get to the end. Confirmation. How do you know for sure that the tip is where it needs to be?
Well, if you used fluoroscopy the whole time, you saw it. You have immediate visual proof and you're good to go.
And if you didn't?
If you did it without that real-time X-ray, then you absolutely must get a post-procedure abdominal X-ray. That is non-negotiable. You need that final verification before you start any feeding.
It all just comes back to how this incredibly intensive, detailed procedure, it all relies on these tiny little prep details for a fix that's only going to last a couple of weeks.
It does, and that mastery, combined with the pressure for efficiency, it brings us to this core tension that we saw in the material.
Which is what?
That sometimes this exchange of the scope and wire can be done without fluoroscopy, relying just on the feel, on the skill of an experienced operator.
That's fascinating. That's a real collision between efficiency and certainty.
It is. Where do you draw that line? In medicine, or really any high-stakes field, the line between the speed you gain from pure experience and the absolute need for verifiable visual confirmation.
For patient safety.
Exactly. I mean, skipping the fluoroscopy saves time, it reduces radiation, and it definitely shows mastery, but it puts all the pressure on that clinician. You're basically betting your experience against the chance that a loop formed in the stomach or the tip slipped out.
It's a kind of ethical tightrope walk.
It is. You're balancing efficiency against certainty, all while the patient can't give you any feedback.
A constant negotiation between skill and science. Well, thank you for diving deep with us on this. Hopefully this gave you all a new appreciation for the incredible precision required in these procedures, even the temporary ones.
My pleasure.
Keep diving deep into the material that matters.